Please start, sir.
Hello and good evening, everyone. Once again, to this DMPG Masterclass program, which is intended for all the DMPGs out there. And this is a unique platform presented by Macleods Pharmaceuticals Limited to you. And I'm sure you have been enjoying all our episodes in the past weekend. Today, we have on board Dr. Ritvik Ghoshal, who will be presenting his case. And for introduction of the entire panel and the expertise what we have today on board, I request Dr. Shami Prajapati from the Medical Affairs team of Macleods Pharmaceuticals to give a small introduction to all of them. Dr. Shami, to you.
Thank you, Mr. Robin. A very good evening. Very good evening to our senior faculty, senior doctors, and our fellow doctors. So welcome you all to yet another Cardio PG Masterclass program. The objective of this session is to facilitate learning and empower young and budding cardiologists in their upcoming exams. So to brief you all, we have Professor Dr. Ajay Mahajan sir and Professor Dr. Kamal Sharma sir as our course director of this program. And the topic, the case presentation by PG student would be on the topic young ischemic heart disease, and which would be followed by keynote presentation on topic coronary imaging, IVUS and OCT by our esteemed speaker, Dr. Rabin Chakrabarti. These are our esteemed senior faculties who are part of this program. And I now have the honor of introducing our esteemed faculties, our course director, Professor Dr. Ajay Mahajan sir, who is Senior Consultant Interventional Cardiologist, HOD of KEM Mumbai. We have Dr. Kamal Sharma sir, Senior Interventional Cardiologist, practicing at Sal Hospital and UN Mehta Institute of Cardiology, Ahmedabad. And for today, we have Dr. S.C. Mondal. Sir is currently Professor and HOD of Department of Cardiology, IPG MER and SSKM Hospital, Kolkata. We welcome you, sir. And we have Dr. Robin Chakrabarti, sir, who is our esteemed faculty and also our speaker for the day. Sir is Senior Consultant Interventional Cardiologist and Electrophysiologist. He is Senior Vice Chairman of Cardiology Services at Medica Group of Hospitals. We welcome you all. And lastly, we have Dr. Ritvik, who would be presenting the case today. And with this, I hand over to you. Dr. Ritvik, you can present.
Okay. Yeah, good evening, everyone. This is Dr. Kamal Sharma, and it's a pleasure. And we have senior, very esteemed faculties, Dr. Rabin Chakrabarti and Dr. Shankar Mandal, head of the department with us. Professor Mandal, welcome. So pleasure to have you, and we'll be going through this moderation and case presentation on young CAD, young coronary artery disease case. This is something that every passing out postgraduate super specialist cardiologist will be facing on day-to-day basis. And we thought that this should be a part of curriculum of learning and also case presentation, because this is what they do day in and day out. Though a lot of universities still don't keep a long case on a young CAD, but I think that's very important and mandatory as to how the ischemia is to be revascularized, especially ischemia-driven revascularization, so that the learning is complete when the exams are taken on that aspect. So over to Dr. Ritvik Ghoshal for case presentation, as we'll have Dr. Professor Mandal and Dr. Robin Chakrabarti to ask you questions, and so along with them, myself as the faculty. Best wishes.
Good evening, sir. Professor S.C. Mandal, sir, my HOD, sir, Dr. Kamal Sharma, sir, and Dr. Robin Chakrabarti, sir. Sir, today my case presentation will be on young ischemic heart disease. So, sir, I'll be presenting one case, and after that it will be a image-based case where I'll be discussing the case in a case. So, sir, my case is a 24 years old young man who is resident of Behala, Kolkata, engineer by occupation. He was non-hypertensive, non-diabetic, and he was smoker for last 4 years. So this patient, he developed sudden onset chest pain with severe sweating and palpitation 9 a.m. in the morning while he was in the local market. He experienced this squeezing, choking type of chest pain, which he never felt before. The chest pain was continuous since the starting of the event without any relief. He came to us after 1 hour of the presentation, and chest pain was radiating to the left shoulder and the left arm. He had some family issues for which he was under stress, and he came to us with a clenched fist in his chest. So this patient presented to us with a history of acute onset severe chest pain with feeling of doom and profuse sweating with radiation to the left arm. So this patient, we asked for the negative history, where this patient did not have any prior history of fever, hemoptysis, cough, or expectoration. He did not have any syncope, nausea, vomiting. He did not have any history of prior immobilization, prolonged travel, calf or leg swelling or pain. He did not have any history of back radiation, of chest pain, or there was no history of paresthesia of forearm, and there was no relation with posture change. Patient also did not have any history of dyspnea or fatigability prior to this incident. So after taking this negative history, we took the personal history, where the patient was known smoker for 4 years. He was occasional alcohol drinker and occasional cannabis intake was there, but no history of cocaine intake was there, because we asked this because the patient was young. So we repeatedly asked this question. And family history was significant. His father, he died at the age of 45 years, and his elder uncle, who passed away at the age of 57 years due to cardiac arrest. Now, sir, after this history, this patient of acute onset chest pain with negative history, which I have mentioned, sir, should I come to the differential diagnosis, sir? Hello?
Yeah, very quick, whatever you want to, just very quick, and then come to the main point.
Yes, yes, sir. So, sir, my differential diagnosis will be, because this chest pain was acute onset and obvious in nature. So my first diagnosis was acute myocardial infarction. Though keeping in mind regarding the acute onset chest pain, I also had some differentials in form of acute pericarditis, aortic dissection, pulmonary embolism, spontaneous pneumothorax, peptic ulcer disease, pancreatitis, acute cholecystitis, costochondritis, strain, or panic disorder. So
you didn't feel that the pain was classical angina? Can you differentiate from history a typical and versus atypical angina?
Yes,
Why you have to keep a differential ranging from strain to acute myocardial infarction, from lower down in the abdomen pancreas to right up there into the spontaneous pneumothorax? You cannot have such a huge differential diagnosis for the chest pain. Do you think that this is justified for the nature of pain that you described to be having a 11 differential diagnosis?
No, sir. It was typical of
are you enlisting causes of chest pain, or you're giving me a differential diagnosis?
Sir, these are the causes of acute onset chest pain, sir, which I have mentioned. But actually, I have only acute myocardial infarction, acute pericarditis, or aortic dissection in my differential. If you, sir, ask me regarding
so what makes you think this chest pain is cardiac or a non-cardiac one?
Sir, this is a typical angina. So, sir, I'll keep it as a cardiac chest pain, sir. And because this patient did not have any history of cough, hemoptysis, or any other back radiation, so aortic dissection or pulmonary embolism, those are less of probabilities. And also there was no history of any form of fever or something. Myopericarditis is also, sir, can be of no use, sir.
So who described angina?
Sir, hello?
Who described angina?
Sir, angina was described. So it was actually Greek word. The word came from anchos, which is kind of chest discomfort. Some demon in Greek mythology, he was sitting on the chest of a patient. So that picture actually, sir, told us regarding this angina.
Heberden described the angina. The same Heberden who described Heberden's
yes, it means a crying of heart. I think what is important, Ritik, you need to understand. It's very simple. Make it things very simple. This young man with a very strong background of ischemic heart disease in the family,
Yes,
the
sir.
pain that is described looks
Yes, sir.
more like an acute ischemic cardiac pain.
Yes, sir.
And therefore,
Yes,
from the history point of view, and you did not find anything abnormal on examination, I believe.
No, sir.
And
No, sir.
then,
Nothing was there.
so I would like to have only 2 or 3. So this is, you can't
Yes,
call
sir.
acute myocardial infarction. You have not done ECG as yet, no?
No, sir. Sir, after that,
Right.
we will
Right.
go for
So,
DCG, sir.
so
Yes, sir.
to make a diagnosis of acute myocardial infarction, there has to be some criteria.
Yes,
One is
sir.
prolonged precordial chest pain,
Yes, sir.
with blah, blah, blah. Then,
Yes, sir.
along with the electrocardiography changes, then cardiac enzymes, and nowadays they also incorporated echocardiography findings.
Yes, sir. Yes, sir.
Which these 3 you don't have. So
Yes,
you
sir.
cannot say it acute myocardial infarction.
Yes, sir.
You can
Yes, sir.
say acute cardiac
Cardiac issue.
cardiac ischemia first.
Yes, sir.
And then
Yes, sir.
maybe pericarditis or dissection, that's it, pulmonary if at all. Remaining
Yes.
is out. Why you are unnecessarily sort of, you are giving a list of chest pain.
Sir, so these are the cause of acute onset chest pain, sir. That is
No,
why I
it's
mentioned.
not
sir.
chest pain. This is the pain
Yes.
that you describe, which such
Typical.
this is my first possibility.
Yes, sir.
To
Yes, sir.
confirm, I have done ECG showing this, then showing
Yes.
this.
Yes, sir.
Then
Yes, sir.
out of 3, if you have 2, diagnosis
Yes.
done.
Okay.
Dr. Ravin,
Yes, sir.
Yes.
he has kept only that diagnosis for differential diagnosis for sake of theoretical discussion. In fact, acute myocardial infarction is the diagnosis with the history of this patient and history of family history like that.
So no point of giving a whole list of chest pain. There's a big list of chest pain. It's a wastage of time.
Okay, sir.
Proceed.
Yes, sir. So, sir, after that, we went for quick examination where the normal general survey, like no pallor, no sinuses, clubbing, edema, jaundice was present, but the patient was profusely sweating and no peripheral stigmata of dyslipidemia was there. Pulse was regular, 120 per minute. He was tachycardic and normal in character, but there was no radial delay was there. Blood pressure was 106 by 72 millimeter of mercury in both upper limbs. JVP was not raised. So we quickly went for the cardiovascular examination where the first and second heart sound is of normal character and there was no additive heart sound. So respiratory system examination was also normal vesicular breath sound both sides, and the patient was in severe chest pain, so no percussion was done. So now we took the ECG, sir, in the emergency. So this is the ECG of this patient where we can see that there is ST elevation from V1 to V6. There's extensive anterior myocardial infarction with reciprocal change in lead 2, 3, and AVF. So, sir,
So what are the differentials of ST elevation? Let's put it that way.
Yes, sir. Sir, in this case, sir, as there is, sir, frank ST elevation with reciprocal change, sir. So this is the clear-cut picture of acute myocardial infarction. And because there is no diffuse STT changes, so sir, pericarditis and all other probabilities are, sir, are mainly eliminated. So this is of, sir, ST elevation with the reciprocal change. That can be because of 2 things. One is because of the reciprocal change, and another is like non-infarct related artery that has also ischemia. So that can also cause the ST depression in lead 2, 3, and AVF. So there is no typical change of pulmonary embolism like S1 QT33 RBB or RVH. So there is no such picture, and also no picture of pericarditis like diffuse STT changes.
If there were no reciprocal changes, how would you differentiate early repolarization from, say, this ST elevation?
Yes, sir. Early repolarization, sir, there is like the T by ST ratio, sir. If it is less than 0.25, this is more than 0.25. This is more towards early repolarization, but with V2 to V5, it generally occurs. Sir, without any reciprocal changes, it can also be seen in early repolarization syndrome. But in the background of this chest pain, severe onset chest pain with this profuse sweating, sir, ERP can be ruled out, sir.
So is early repolarization a benign thing or not a benign thing? Suppose you find the patient, he turns out to be early repolarization. What would be your explanation to him or his family? What should he be watchful or not watchful? Be okay with it? Nothing to worry at all ever?
No, sir. Actually, ERP is a benign thing, but in 10 to 15% of the cases, it can turn to ventricular tachycardia or VF, sir. It can also cause this in future. So they have to be cautious. 10 to 15% of the cases of ERP can lead to VT-VF.
Yeah,
So,
they
sir,
are
benign,
increased risk of SCD,
yes,
correct?
SCD. So that is why, sir, BERP is sir, misnomer. It is ERP, but BERP should not be mentioned.
What about at the different? So angina, you were saying. Can you tell me a non-coronary cause of a classical angina?
Sir,
you don't have coronary artery disease, but you have classical angina.
Sir, non-coronary artery disease, classical angina can be seen in, sir, in pericarditis also, but that is not classical, sir. And it can be seen in, sir, in like in aortic stenosis or in mitral valve collapse, or, sir, HOCM can also present. Those are the cardiac disease where, sir, non-coronary artery disease, sir, chest pain can be there, or also in pulmonary hypertension also due to RV ischemia.
Classical,
So,
you get it in aortic stenosis, hypertrophic obstructive cardiomyopathies.
Yes, sir.
Can have mitral valve prolapse and others
not classic.
atypical.
Atypical, sir. Yes.
Right. So, Ritik, when you sort of describe the ECG of this patient,
yes, sir,
I think your description should be much more complete. So, you describe that this patient ECG shows that the patient is in sinus rhythm.
Yes, sir. Yes,
the first thing. Second, you said out of the abnormalities, there is a clear-cut ST segment elevation, which obviously obvious from V1 or V2 onward probably.
Yes, sir. V2,
V3, V4, V5, or even V6.
Yes, sir.
Right?
Yes, sir.
And then you also describe that in that ST elevation, if you look at that junctional point, you can see the J point. J point is quite off. And then if you look at especially V3 and V4, is J point is nearly 2.5 square, nearly 2.5 square above the isoelectric line. And in fact, in lead 3, J point is nearly 4 small square above the isoelectric line. So D2, V3, J point is above more than 2 or 3 small square above the isoelectric line. And there in V5 it is, and V5, V6 more than 1.5 square.
Yes, 1.5.
This indicate this is a very nice, there is very nice paper being published and from this group from Texas Heart Institute, and there is a scoring system, and the scoring system says that you can actually stratify the risk of this acute ischemic syndrome or acute mitral infarction, and how this patient will behave eventually if you do not treat them appropriately, right? And this gentleman who actually described this, he came to India and presented his work, and we are very fortunate to share our sort of his ideas with us. That has to be mentioned. So this is a nice scoring system that has to be described.
Okay.
And clearly there is no other arrhythmia, and there is
no arrhythmia, sir. Yes,
right? But it's from V2, V3, V4, more in V3, V4.
More 3, V4.
Right. And there is no bundle branch block or
no bundle branch block.
So that indicates the location, and is worth mentioning that you said there is no reciprocal change, which is not totally correct. If you look at lead 3 and AVF, there is ST depression.
It's there, sir. It's there.
Right? So that also has a meaning. That means the area subtended by LAD territory is affected, and is a significant area because there is depression. That means it has actually affected a huge area. If you would have seen the ST elevation even at 2, 3 AVF or 3 AVF, then probably electrocardiographically it looked very wide, but actually it is a small area of myocardium getting affected.
Yes, sir.
Go ahead.
Can you predict where is the lesion?
Sir,
based on the ECG?
Sir, it is, sir, in the proximal LAD, sir, based on the ECG, sir.
So ECG based description of localization is not like that, proximal mid distal. You have to say
sir, before the
first diagonal.
Yes, sir, before the D1, sir. Yes, sir, first diagonal. Sir, before the first diagonal, not before the first.
Before the first diagonal, but after the first.
After the first septal, sir.
That is the complete description.
Yes, sir. Yes.
First diagonal will have shown something because first diagonal or first septal, sometimes if that gets affected, they get compromised and creates problem. First diagonal would have created much more abnormal, especially if you look at the AVL.
Yes, sir.
Right. See, AVL is very subtle. The first diagonal would have been a very prominent one.
Yes, sir. One and AVL will show, sir, the first diagonal.
So it is mostly between first diagonal
and first septal.
Or maybe between above that, around that region. Right. Okay, go ahead.
Yes, sir. So, sir, we quickly went for echo examination. Sir, I could not show the echo video because it's one in the ER. So, quick echo screen showed anterior hypokinesia without any mechanical complications. So, sir, there was no MR, no ventricular septal rupture or any other mechanical complications. So, sir, this patient was
anterior only, or you're meaning with the LAD territory?
Sir, LAD territory, sir. Actually, anterior.
That is anterior. That is more than that.
More than that, sir. It's anterior anteroseptal and anterolateral hypokinesia. That is the LAD territory. Sir, in the mid basal and
so what part of the septum is not LAD territory?
Sir,
what part of the septum is not LAD territory, and what part of which is not septum but still is an LAD territory? You remember the bullseye diagram and representation of vessels?
I remember, sir. It was in bronze.
So when you present a case of coronary artery disease, these are the unusual questions. When you are more prepared on clinical aspects, somebody will tell you pulse, you'll not be asked. You'll be asked on questions which are tracking in different direction, completely localizing territories, angina, descriptions of angina.
Sir, the lateral one, sir, because it is supplied by
basal septal is supplied
by circumflex, sir. So, sir,
it's
by circumflex, sir.
Not totally.
Not totally. By
so posterior descending artery supplies what part of the septum?
So PDA supplies this basal septum, sir.
Yeah, so that's why that will not come from the LAD, no?
Yes, sir. Yes, sir. Posterior basal septum. So, sir, that can be supplied from RC also. That can be supplied from the SARC also, sir.
For the PDA.
PDA, exactly, sir.
So you have echo images to show?
No, sir. Sir, actually, it was done in the ER, so we could not save it, sir. So
what other things? Suppose this patient comes, apart from the hypokinesia and regional distribution of hypokinesia, mechanical complications apart, like, so you've looked at mechanical complications would be 3 of them. What are they?
So one is acute mitral regurgitation.
Right.
Sir, another is ventricular septal rupture. As you said, sir, in the basal septum or in the anterior hypokinesia, is in the apical part or in the inferior hypokinesia, or sir, there can be a LV aneurysm, sir, but that takes time, sir. It's not
clinically. Do you suggest that patient have acute mitral regurgitation? Patient does not have any, in fact, heart failure, neither in cardiogenic shock.
Yes, sir.
So acute mitral regurgitation usually the patient with LVF, number 1.
Yes,
number 2, very difficult to see echocardiography acute mitral regurgitation unless and until you just see patient in cardiogenic shock and the hyperkinetic walls.
Yes,
mainly, if you see the hyperkinetic walls and patient having cardiogenic shock, you should think about that acute MR.
Yes, sir. Yes.
And acute MR doesn't happen with LAD territory. It's a circumflex, no?
Yes, sir.
Sometimes also it occurs in LAD territory.
Yes, sir. So, like if it in the anterolateral papillary muscle, sir, that can be supplied by LAD.
Exactly. So here the lateral wall is not much; it's mostly the anterior part.
Yes, sir. Yes, sir.
That's why your echo shows only anterior. Did not talk about the lateral wall.
No, sir.
ECG also does not suggest
lateral.
Some changes not very significant.
Yes, sir.
That's some. Anyway, go ahead.
Okay, sir. So this patient was presented to us within 1 hour. So this patient was taken for primary PCI in our cath lab. Sir, here we did the angiogram. Like after the first shot, sir, RCA was normal. It was done with a stick catheter, 5 French stick catheter. And after doing this RCA shot, sir, the patient developed rashes and some sort of respiratory discomfort. So, sir, we quickly did the left shot, which showed, sir, complete cutoff of the LED from the proximal part. Sir, here you can see that the occlusion is after the diagonal, after the first diagonal, sir. So it is completely cut off. But after doing this angiogram, this patient developed severe dye reaction in form of bradycardia, hypotension, bronchospasm, and erythematous rash. So all symptoms suggested to the diagnosis of severe dye reaction. So, sir, we thought about doing primary angioplasty without contrast. So we are planning about zero contrast PTCA in this patient. So after stabilizing this patient with hydrocortisone and with anti-allergy, antihistaminic drugs, the LMC was engaged with a 6 French EBU 3.5 guide catheter, and then the wiring was done with run through floppy wire, and a small 2.20 into 15 semi-compliant balloon was taken for daughtering, but there was a tight lesion in the proximal LED, so the balloon could not pass this lesion. So here we had to dilate this lesion with at 14 atmospheric pressure. Sir, after that, we did IVUS to have a proper longitudinal bookmark, to have a proper bookmark from the landing zone of the stent from the distal to the proximal. Sir, initially this vessel was thought to be, looking at the vessel size, it was thought to be at 2.75 millimeter at most, but sir, LED was thought to be 3.5 millimeter. Sir, here with the IVUS run from the distal LED, we can see high plaque burden. It's a eccentric kind of plaque, sir, with some sort of thrombus in the lumen, sir, also can be seen. Huge plaque burden you can see from the distal LED we are approaching. Here is also huge amount of plaque with some thrombus. So huge plaque burden coming in the proximal part.
So what are the non-atherosclerotic causes of coronary artery disease or myocardial infarction?
Sir, non-atherosclerotic causes are mainly, sir, like in form of microvascular dysfunction, coronary embolism, spontaneous coronary artery dissection, or sir, coronary spasm. These are the non-atherosclerotic. But myocardial infarction can be due to also, sir, bradyarrhythmia, hypotension. Sir, in this case, this is the SART is coming, sir.
What is type 2 myocardial infarction?
Sir, type 2 is because of increased demand, sir, due to supply demand mismatch, sir, due to anemia, due to hypotension, or due to, sir, tachyarrhythmia also. Sir, this
Any
is the
infection
type.
that you know which was very preponderantly associated with type 2 MI?
Sir, couldn't get you, sir. Sir, can you repeat, sir?
Any infective etiology which was very often of lately associated with type 2 myocardial infarction?
Sir, infective endocarditis.
Infective etiology.
COVID-19.
COVID-19. Oh,
you had a lot of patients who presented with type 2 myocardial infarction as well.
Okay, sir. Okay.
Angiograms would be normal, biomarkers will be positive, echo would show a regional abnormality, STs would be elevated.
Okay.
Also, disorders where you can have like disorders. Can you have aortoarthritis causing coronary artery disease?
Yes, sir.
Those are the disorders. When you are asked, the list should be completed.
Okay,
should also include disorders which are more preponderant. Coronary involvement is more common in our part of the world as compared to.
Yes, sir. In Takayasu arteritis, giant cell arteritis,
even Kawasaki
disease, sir. Spinal polyarteritis nodosa.
Those are expected at DM level. That should be covered. Yes. So, what do you think here etiology is?
Sir, it's a case of atherosclerotic disorder, sir. The etiology is
now again, what would you be anticipating in a young patient like 27-year-old in an atherosclerotic MI to be an etiology of myocardial infarction? Are you getting my question? So what are the ways that a atherosclerotic plaque can yield acute MI, pathophysiologically speaking?
Sir, the most common cause is plaque rupture. And
correct.
Second
plaque
most
rupture,
common is
plaque erosion,
plaque erosion and plaque erosion. These are the two most common causes, sir. And
So
other
what is
than
more
that,
common in young adults?
sir, young adults erosion is more common, sir.
No, one more thing. No, what is
Yes,
TICFA?
sir, TICFA is thin cap. Thick, sir, this is like fatty. Sir, sir, this is thin cap
Fibrous atheroma.
Yes, sir, fibrous atheroma. Yes, sir. Fibrous atheroma.
That's very common in young age. Very common.
Yes, sir. Yes, sir. Those are notorious for plaque rupture, thin cap.
What are the criteria of the same?
Sir, like more
How
than.
do you identify that?
Sir, in OCT, sir, it is identified in form of more than 65 micrometers, sir. If it is
More or less?
Less than
Less
60.
than.
Sir, less than 65, yes, sir. Thin is less than 65, more is more than 65. Yes.
And proportion of?
So proportion of there is a high lipid in thick cap and in low lipid in thin cap.
Is it lipid or something else?
Sir, macrophage and lipid both are there.
Macrophages.
Macrophages. Yes, sir.
Yes.
Yes.
So finally, what happened?
Sir, so sir, here in this case, sir, we can see the distal LM also had disease, and SARC was apparent disease free in this picture also, sir, which is running. So after that, sir, SARC wiring was done to have a landmark for ostial LED stenting. Like we wanted to stent from distal LM to LED, and we had a transverse picture which I don't have here, sir. So we had the bookmark where we have to land in the distal part, in the proximal part. So this is the landmark, sir, the LED and SARC. And after that, sir, we did the PTCA from LED to LM. It's a 3.5 into 38 milliliter DES at 14 atmospheric pressure. And the SARC ostium wire was the landmark, sir, for distal LM to LED stenting. And after that, we did the post-IVUS run to check the stent apposition. Here the stent is properly apposed, sir. From LED to LM, we are having IVUS pullback. The stent is properly apposed throughout, sir. And SARC ostium is also coming here, the 3 o'clock position, and which was apparently disease free. Sir, so though this patient had severe direction, ideally we should not take any further shot because we are satisfied with the IVUS run. But for our cath lab technicians' interest, we had to take the final shot. So this is the 2 ml dye only to check the final result. We have TME3 flow without any dissection. So in this case, the dye reaction is not very uncommon. IVUS guided PCI is extremely helpful in such situation. Concept of zero contrast PCI is evolving. So this is the case, sir.
So how will you work this patient up for?
Sir,
his etiology? Is it usual, common, uncommon?
Sir,
27-year-old to present
yes,
with
sir.
it.
Yes, sir, it's quite uncommon. So, sir, it would have been nice if we had some OCT, but sir, OCT could have clarified the plaque regarding the plaque rupture or erosion or any SCAD or any other intimal things, sir. And we also had to work up regarding his lipid profile because this patient had similar family incident in from his father and his elder uncle. So, sir, the LDL. Yes, sir.
You discuss the antithrombotic of this patient.
Sir, antithrombotic. Yes, sir.
What anticoagulant you use? What antiplatelet
yes,
you use?
Yes, sir. Sir, we loaded this patient with 325 milligrams of aspirin and sir 80 milligrams of atorvastatin and 180 milligrams of ticagrelor. And then, sir, after that, post PCI, this patient was continued with 75 milligrams of aspirin.
Now, whether you use heparin or bivalirudin?
No, sir, we went with heparin, sir. Bivalirudin was not available in our cath lab. And
how much ACT you kept? How much heparin you have given?
Sir, ACT we kept, sir, more than 400, sir, and heparin was given at the rate of 100 units per kg body weight, and in the patient was 75 kg of weight, so we administered 7,500 milligram units of heparin.
Have you gone to Bright Fort trial?
Sir, this is yes, sir. This is regarding bivalirudin, sir, which is showing, sir, a good mortality benefit after 30 days, and similar efficacy, sir, without any increased bleeding risk.
What is the problem of horizontal AMI or acuity with bivalirudin?
Sir, in both of these trials, they have seen that the first day the increased, sir, stent thrombosis rate is high in the initial part, but it was not there after 30 days.
2 hours. Initial
Yes,
2 hours.
Initial 2 hours, sir.
That's why in Bright Fort trial they continued at least for 3 hours.
3 hours, sir.
After completion of the procedure.
Yes, sir. Yes, sir. Yes, sir.
And regarding lipids, the patient has family history of
yes, sir.
coronary artery disease.
Yes, sir.
So whether there is hereditary familial hyperlipidemia in this patient, though we have not got any peripheral stigmata
yes, sir.
of hyperlipidemia.
Yes, sir.
What is his LDL cholesterol?
Sir, LDL cholesterol was done later on, which was 130 milligram per DL, sir. It was high.
130.
Yes, sir.
Then what is your, in fact, target and how will you do that?
Sir,
lipidemic agents in this patient.
Sir, this patient, sir, did not have too much of high LDL, 130. So, sir,
130.
Oh, sir,
so
70.
Less than 55.
Yes, sir. 55 was target, sir. So he was on
less than 55.
Less than 55.
What should be the combination or what your therapy should be given?
Sir, like high dose statin, because this patient has ASCVD, so high dose statin was administered in form of atorvastatin 80 milligrams. And if the reduction was not more than 50% of
no. What we do? We do actually combination therapy.
Yes, sir.
In high dose statin, you cannot decrease the cholesterol at 55 milligram in ACS patient.
Yes, sir.
So most of the patient, what we do? We do statin plus ezetimibe. Most of the patient.
Ezetimibe, sir. Yes, sir. Statin plus ezetimibe. The combination. Yes, sir.
So what are the Simon-Broom criteria of FHF?
Sir, sir, there are 5 types of hyperlipidemia, sir. Like type
that is
1.
Fredrickson.
I'm
talking Simon-Broom criteria of familial hypercholesterolemia. There are some LDL values that if you get, you know this is a major criteria. So cutoffs like
you rate these things, you just tell.
Yes, sir. Simon-Broom, sir, I haven't read, sir.
This is one you should know, young 27-year-old. So a young family history is one of the minor criteria.
Yes,
genetic polymorphism documented is a major criteria.
Major criteria.
There's LDL values of more than 190 and 210. Those are the two great ones for hetero versus homo. You should read them. Other is the Danish criteria and the WHO criteria. 3 of them to diagnose FHF. Mutations we cannot do for all young patients. So you have to go by the LDL cutoff,
LDL level and
Simon-Broom clinical criteria. Okay. What other risk factors you know of? What are the common traditional risk factors of coronary artery disease?
The traditional risk factors are like sir, hypertension, dyslipidemia, obesity, hyperglycemia, like diabetes, and also smoking. These are the traditional risk factors for coronary
these don't complete the list of 10. When you're asked about this, you should be talking about at least inter-heart based criteria, right? Inter-heart is one of the largest data that is looked prospectively across 52 countries, more than 1 million patients, and attributable risk of 90% between those 10 of them. So inter-heart is one of the studies which has established what 10 risk factors, and you should know all 10 of them. Is alcohol in moderation protective in Indians? That's the next question.
Sir, in moderation, it's protective, sir, but not in Indians, sir.
No, in Indians it is not. This is the other thing.
Sir. In the
So in overall sub-cohort, there was benefit, but in Indian cohorts, when it was separately analyzed by the ICMR, The
was not
protective
beneficial.
benefit of alcoholism does not hold true. So alcohol, 1 peg a day as a medical prescription will not hold true
Yes,
in
sir.
India.
Yes, sir.
Okay.
Yes.
So those attribute 10. So what are the other lipid abnormalities, or what is typical Indian lipid profile? Most of the Indians will not come with LDL of 190,
no, sir,
right?
they come with high triglyceridemia, sir.
Yes.
Triglyceride is high.
Elevated TG, borderline or slightly high LDL, like this guy has,
Yes,
low
sir.
HDL.
Low HDL.
And what is the LDL morphology?
Sir, morphology is like,
You know what is LDL morphology means?
sir, like ideal LDL.
No. LDL morphology means
No,
small dense LDL and large buoyant LDL.
Particle. Yes, sir.
Particle size.
Particle size.
Particle size wise. Yes, sir.
So Indians, how is it? Large or small?
Small, sir.
Small dense
Small.
LDL.
Small dense, sir. Yes.
And
Those are of-
lipolittle A.
LPA, sir. Lipoprotein A also.
So that's also
High.
more common in
Yes, sir.
Caucasians or Indians.
Sir, Indians have more than 70, sir, risk factor.
More than
70, sir. In 50 in outside India, but in India it's more than 70.
no.
The cutoff value.
What is the prevalence
Sir,
of lipolittle A?
prevalence is like, sir, I guess that 5 to 10%. Sir,
No,
I'm not
it's
sure.
30%.
30%.
Yeah, 10% is in Caucasians, 30%.
Yes, sir,
And
yes, sir.
are we the
Caucasians.
genetically highest lipolittle A elevated race, or somebody else has even more?
Sir, Hispanics, I guess,
Race is
sir, are,
most likely to have elevated lipolittle A.
sir, Hispanics, no?
Ethnicity. Sorry?
Sir, Hispanics are more prone
No,
for
not Hispanics, African blacks.
African blacks.
They have the highest prevalence.
Okay.
How do you treat lipolittle A?
Sir, those are not, they can be treated with statins. So PCSK9 inhibitors are the treatment of choice for lipoprotein A, sir.
Right.
High lipoprotein level.
So only way you can do it is by PCSK9. But suppose everybody cannot afford PCSK9. So what do you do?
Sir, for lipoprotein A, sir, you cannot do with
Does
lifestyle modification.
niacin lower lipolittle A?
Sir, some studies have shown, but not too much, sir.
No. It does
No.
lower lipolittle A pretty well, but you still don't use it. So that
Because
was my question. Why?
Yes, sir. Yes, sir. They have many side effects, sir, niacin.
Is it because of the side effects that you don't use? Suppose you have laropiprant. You know what is laropiprant?
Yes, sir. Yes, sir.
So it blocks the side effects of it.
Side
Then you can
effects
give, na? What's the problem?
Yes,
Can you? No, you don't. Why? That's the question.
sir.
So
They
aim
follow
high study,
hyper-
what were the
Yes, sir.
increased signals? There was increased stroke rates. So
Yes,
despite lower
More
improvement in
stroke rates.
HDL,
Yes.
despite improving HDL with niacin, you had higher stroke rates and more
Higher stroke rates.
hepatotoxicity.
Yes, sir. Yes.
Despite reduction of, so overall there was a negative trial.
Yes, sir.
And that's why niacin fall out of vogue.
Yes, sir. Aim high study.
So what are the novel cardiovascular risk factors apart from lipolittle A?
Sir, others are like CRP, cholesterol.
HSCRP, correct?
Yes, sir. HSCRP, cholesterol level, and also IL-6 level.
Novel. Rutvik, that's an old one. Novel are, Brunwald clearly mentioned these are novel. That's it.
The GDF15, IL-6.
No, so GDL15, etc. are investigational novel markers. They are not risk factors. GD15 will not tell you'll get MI or you'll not get
Yes, sir. HSCRP and lipoprotein A, sir. These two
correct. And what about homocysteine?
Homocysteine level, yes, sir. More than 100 is also risk factor, sir.
Is it? Is it what class? 2A, 1B, 2B?
Sir, which class, sir? I don't remember.
No, this you should know by heart. These you should know. Lipolittle A and HSCRP is class 1.
Yes,
Lipolittle A is class 2A and homocysteine is class 2B. So homocysteine does not go with coronary artery disease as strongly as compared to lipolittle A or HSCRP, which of course we know. How else you can prognosticate? Nowadays, a lot of young guys are dying. How do you prognosticate a young CAD patient?
So,
is CAC one of the prognostication criteria in AHA guidelines?
Sir,
coronary artery calcium
coronary calcium is there, sir.
So whom will you do? Everyone? Now that everybody is worried, young guys dying everywhere around.
No, sir.
Young
family history,
died.
I think family history is important. Like,
is it family history or
And
there are some risk score calculators.
yes.
What are the risk scores calculators that you know of in CAD?
Sir, ACVD calculator is there.
Correct. That is one.
Yes, sir. Another, sir.
Any other risk calculators?
Sir,
Have you heard of QRisk?
yes, sir. QDC is also there, sir. It's an app, QDC.
So QRisk 3 is the
Yes,
current
sir.
version.
QRisk
What's
3.
the advantage QRisk has over ASCVD? Which one of the two you will use? That's first question. There's one more, WHO, JBS. There are multiple, right? But
Yes,
QRisk has one advantage compared to
sir,
the other.
easy, sir. It's easy to calculate, sir.
No,
QDC
it's
has
not
a
easy to calculate. Actually, it's app. All of them are app based.
app based, sir, actually.
But easy, that's not the reason. The reason is that Indian ethnicity can be counted separately.
Okay.
So it's the one that is using ethnicity to be Indian, Bangladeshi, Pakistani, because
Okay.
it's the NHS data of the immigrants from which country they have done it, and that's how they've stratified.
Okay,
And it also includes other novel CV risk factor predictors like rheumatoid arthritis, SLE, migraine.
Yes, sir.
So they have looked at that, and those are more common for stroke, but CV risk outcomes, not cardiovascular coronary artery disease, but CV outcomes. So how long DAPT for this guy?
Sir, at least 1 year, sir, because it's a young man, sir. So 1 year is important, sir.
So beyond a year, what will you give him?
Sir, beyond year, single antiplatelet will be continued, sir.
Aspirin or clopidogrel, a single one?
Sir, aspirin, sir. Aspirin.
Any negative trials of aspirin that you know of?
Sir, negative trial.
So aspirin as a primary prevention strategy should be given to whom?
So those who are diabetics more than 45 years.
Females included?
Female. Sir, females are not included. Sir, females are not included. Male more than 45 years diabetic as primary prevention.
So aspirin to all is no more considered. Three negative trials now that you have. Aspire.
Yes.
Right. So
Ascent.
Dr. Mandal, Dr. Rabin Chakravarti.
He's our student. You just ask the questions.
Nothing much. I think this is, we have already finished nearly 55 minutes. We should proceed to the next case.
So I think he did pretty well. Thank you very much, Dr. Ritvik Gosal.
Thank you,
we
sir.
wanted to basically being instrumental in others learning through your presentation.
Yes.
And it requires a lot of courage to be on a platform like this, nationally being visualized by more than 500 students, and you getting a grilling session by all the esteemed faculties. So thank you very much. And now I invite Dr. Robin for his presentation.
Thank you, sir. Thank you, sir.
No. Kamal?
Yes, sir.
Is there any one more case presentation? No.
No, sir. So your talk for the day is next. Yes.
So I'll just I'll share my screen. Give me a second. Let me. So in continuation with the previous, 1 minute. Am I visible? No.
Yeah, it is visible.
In continuation with the previous presentation, I'll start my talk, and my talk is on image-guided coronary intervention. So, image has really created a revolution in the management of intervention in coronary artery disease. What we try to do, we look at through the transducer, we emit high-frequency sound wave, and sound waves are reflected back to the transducer from tissue structures of different intensities. And therefore, by doing so, we actually get an image and try to make some meaning out of that. So high-frequency sound waves, echo of vessel walls, are sent back to the system, and the system, the electronics, they change it to an image of different morphology, and accordingly, we try to identify the vessel lumen, the vessel wall, various segments of the vessel wall like tunica adventitia, tunica media, and tunica intima, and the surrounding structure. In addition to that, whatever may be the abnormalities, be it atherosclerotic plaque, be it thrombus, be it calcium, be it fibrocalcific region or pure fibrosis, even if all those or mixed nature of plaque, everything can be picked up by this imaging technique. So ultrasound principles, there are two types of imaging system, mechanical and electronic array. The mechanical system rotating transducer is gradually going off. Nowadays, we are actually coming to electronic array sort of IVUS catheters. These are new type of IVUS catheters, and most of us are using that kind of thing, which is called multi-element array, something like an echocardiogram. And it is so tiny, it goes inside the coronary artery and picks up the image from the various areas of the arteries, including the normal and abnormal part of the coronary artery, the physiology, even the pathology. We don't get accurate idea about the physiology, but most of the time we try to get the pathology. So, as I said, that high frequency sound wave echo off vessel wall and are sent back to the system, sending, receiving, processing the sound wave to create a cross-sectional picture of an artery. And then all these cross-sectional pictures are being connected. Therefore, you get a longitudinal length of the artery with its normality as well as the abnormalities. So image quality can be described by two important factors. One is spatial resolution, which is the ability to discriminate small adjacent objects within the image. And for a 30 or 40 megahertz IVUS transducer, the typical resolution is 80 to 100 micron axially and 200 to 250 micron laterally. This is the basic two principles we need to remember, especially for the postgraduate students. They should remember for a theory question also. These are the 2 points what the examiners are interested to know, that what are the two important factors on which the ultrasound or the IVUS works. So one is axial rotation, and which is this way, and lateral resolution, that is this way. So axial resolution, this direction, and lateral resolution on the other direction. That's how the image is being created. This is the basic principles of IVUS. So ultrasound principle, there could be low dynamic range, which is black and white, and only a few in between grayscale levels. This is the one. And nowadays we can have a high dynamic range, just more shades of gray and are often softer. So with time, we are actually getting more high dynamic range of ultrasound. Therefore, to get a better image quality, and even the character of the image can be better identified. Now, based on these two or few principles, let us try to identify atherosclerotic plaque and plaque characteristics. Where is the true lesion? Now, this is an anatomy. We can see this is an artery. There's a critical narrowing over there, but there are certain areas which are again abnormal. Somewhere there, and what about these areas? We do not know. Even if you look at this artery, probably there's a disease segment here as well. So we need to know the entire length of the artery, that what is the nature of this lesion and how it is being distributed. So if you take kind of this very nice slide, which is a gross specimen of coronary artery segment, where it has been cross-section, it's been dissected at various ways, and then you don't even need to find out where is the actual lesion. So this is a pathological segment which has been dissected, by transverse cut, and try to find out the detail of the atherosclerotic nature and the stenotic area of the coronary artery. This image, this reality, this real specimen gets translated by image with the help of IVUS. So the quantitative coronary angiogram, or QCA, which you used to do, I'm sure that Kamal, Dr. Mandal, and we all remember this, that we used to do this QCA in good old days to find out the length of the lesion, the character of the lesion, and what diameter of the arterial diameter. Accordingly, we should choose our stent and deploy them accordingly. But IVUS has replaced to a great extent. Nowadays, seldom we do QCA, especially when you do procedure with IVUS guided intervention. So the advantage is that there's good reproducibility, precise measurements, quick and safe, but limitations are no physiological measurement, probable atherosclerotic reference site, difficulty in evaluation of the eccentric lesion. So these are the limitations that we have with QCA. But then with this kind of IVUS, the advantage is that precise measurements of lumen diameter and cross-sectional area, longitudinal and volumetric measurements, and components of the atherosclerotic plaque can also be understood by intravascular ultrasound imaging technique. However, we have some limitations like unable to evaluate the collateral vessels. Now, of course, there is some kind of cost that we need to understand. And still today, we do not have an accurate physiological evaluation of those coronary lesions. Although there's a new generation probably is hoping to come, where we can actually also get some kind of physiological information. Although the accurate physiological information about across the lesion and the flow dynamics cannot be accurately ascertained with the help of IVUS. But precise measurement of the lumen diameter, cross-sectional area, longitudinal and volumetric measurements, and components of atherosclerotic plaque can be ascertained. Collateral, of course, we have a limitation. So with a mechanical rotating type, as I said earlier, and phased array type, as I said, 64 elements, 20 megahertz, and no guide wire artifact, and and this is a very commonly found in volcano. The Boston Scientific has this mechanical rotating type, single element 40 to 45, and Boston, Teramo, and Volcano also has the same mechanism. So, in fact, nowadays we are more switching over to the phased array because it is an advantage of that. So, what information we get from IVUS? Information that we get from IVUS is vessel diameter, vessel area, vessel the volume. The IVUS can give us the cross-sectional area, cross-sectional volume, diameter, luminal vessel diameter, luminal area, plaque area, vessel area, lumen volume, plaque volume, vessel volume. Components of the plaque also we can get, like low echogenic or high echogenic plaque, lipid-rich or fibro-rich, or a combination. Degree and location of calcium. Where is the location? Is it subintimal or beyond that? Or what is kind of degree? 360 degree, 120 degree, or what is the extent of the calcium if it is subintimal? Especially operators nowadays are using rotablator or even intravascular lithotripsy. And for those kind of usage, it is important to have a knowledge of the degree and location of the calcium. Direction of the plaque. Is it a myocardial site or pericardial site? Is it eccentric or concentric? So those 3 points about vessel, about the component, and direction, these are extremely useful information to determine the long-term outcome of PCI. That is important. IVUS is very helpful for this. Then IVUS measurements. Normally we do 2D measurements, which means we do, this is a media. Media is a dark component. And immediately after that, there is a bright component called intima, and beyond that dark line or dark circle, there's one other white circle that is adventitia. So we can actually do luminal cross-sectional area, vessel cross-sectional area, or plaque and media cross-sectional area. Plaque cross-sectional area is equal to vessel cross-sectional area minus lumen cross-sectional area. This is the plaque cross-sectional area. So you do vessel cross-section area and lumen cross-sectional area. So if you find there's a huge gap, that is called plaque cross-sectional area. Percentage of area stenosis is equal to plaque cross-sectional area divided by vessel cross-sectional area into 100. Then coronary remodeling. IVUS is a fascinating tool to give us information about the vessel coronary remodeling. We know that once there is atherosclerosis of coronary artery, it goes into remodeling. It could be positive remodeling, it could be negative remodeling. So pathophysiological observation of left main coronary arteries from autopsy hearts. This is Dr. Glagov and his colleague had found out that the vessel initially expands outward until the percentage of plaque area reaches approximately 40% of the vessel. Then, so that the lumen area is preserved, then the atherosclerosis progresses to narrow the lumen. This phenomenon is called compensatory enlargement. So when you talk about the coronary artery blockage, remember, we always think that atherosclerosis is encroaching towards the lumen. No, it is not. Atherosclerosis encroaches both away from the lumen and towards the lumen. In fact, the initial approach or initial progress of the atherosclerosis is away from the lumen. After it occupies the 40% of the vessel diameter, then it comes inside the lumen. Therefore, the coronary stenosis occurs. This is a very fundamental understanding of coronary remodeling. That is how this is the kind of artery. Then you can see the plaque first goes outside, it becomes like this, and then it approaches towards the lumen, causing narrowing. That is very interesting and very important for us to understand. So there is a compensatory remodeling, as I told you earlier, the compensatory enlargement and compensatory remodeling is very important, and there lies the secret of coronary artery stenosis. IVUS is an important tool for us to understand this kind of compensatory remodeling of the coronary artery during this atherosclerotic process. It's a degenerative process, atherosclerotic process. So there could be paradoxical arterial wall shrinkage, which may contribute to lumen narrowing. Now, as it grows, there could be the other side of the wall can actually paradoxically shrink and give you an impression that there could be luminal narrowing. For example, like this is an artery, you can see then there is a progressivity is going up, and then there is a paradoxical shrinkage of the lumen causing a stenotic area, which is very important for us to understand. This has been published a long time ago, something like 27 years ago. This was published in Circulation. Then, as I said earlier, the paradoxical arterial shrinkage, which means that there is a deposition. This cannot be picked up by coronary angiogram. So IVUS can easily find out that there is a deposition, and then there is a paradoxical shrinkage of the lumen causing this narrowing. Why it is important? Because if you do an IVUS guided intervention, then you can find out that, well, this is not exactly the luminal narrowing, it is a paradoxical arterial shrinkage. Therefore, if you can deploy the stent properly, the chances of that stent to become further restenosis would be very small. Then also you can find out orientation of the coronary artery and landmark outside this vessel. This is important. For example, we know that from the IVUS, the pericardium is picked up. This is circumflex. We know that this is intima, this is media, this is adventitia. Black one is the media. So the atherosclerosis, subintimal deposit is atherosclerosis, right? Calcification can happen also in the adventitial region. So if you find that subintimal region is free, intima up to media, there is no calcium, only adventitial calcium, then probably this is not going to have major impact on your intervention, unlike if the calcium is in the subintimal region. That one has to understand. So this is one such example when the intracoronary ultrasound and multi-detector computer tomography MDCT data, the coronary artery is divided into 3 mm section. And then you can see that how nicely each segment can be picked up by this mechanism. I'll skip that. Legal system. Then plaque characteristics, like intimal disease. The plaque is dense and will appear white. Media disease, made of homogeneous smooth muscle cell and does not reflect ultrasound. Remember, tunica media will not reflect ultrasound, so it is dark. Adventitia sheets of collagen, so reflect a lot of ultrasound which appear white. So media is dark, intima is white, and adventitia is white. So deposition is there. Plaque is dense and will appear very white. Calcium will also appear white, but it will, the shadow beyond the calcium will be dark because of the echo, because it will not, it's a sound that it will cast a dark shadow beyond the calcium. One is to understand that. That is very important. This is a normal coronary artery. This is IVAS catheter. This is the lumen. This is intima. Then the dark thing is the dark circle is media, and then you got adventitia, and then you got pericardium and other kind of thing. When it is diseased, this is the catheter. This is intima, and then you got a subintimal deposit. Then the thin dark line around it is media, and then this is intima, and then this is the pericardium. You also see that there is a very nice paradoxical remodeling, or the shrinkage of the wall, paradoxical shrinkage of the wall, which is extremely important to observe in a diseased coronary artery. Calcified plaque. This is calcium. Okay? See, this is intima, and then there's the calcium, and then beyond the calcium, this is actually adventitia. So this is media, and then there's a huge calcium, and that casts a very dark shadow beyond that. And same is true, you can spotty calcium there, and then you can see these are the dark shadows. This is basically the shadow of calcium. This is acoustic shadowing, which is obstruct the penetration of ultrasound, causing acoustic shadowing, whatever is found in ultrasound in gallstone disease. The same is true here. Calcium is quantified by measuring the arc. You can actually measure the arc. 90-degree arc makes deep and superficial calcium plaque. So all this can be quantified with a deep calcium or superficial calcium. So these are superficial calcium. This is very deep calcium, 1 quadrant, very deep. It is actually involved the intima and also partly the adventitia, which is important for us to understand. Then this is a fibrotic plaque. There is no calcium. You can see bright as or brighter than the adventitia. This is the fibrosis. Majority of associated lesions are fibrotic. This is catheter, IVAS catheter. This is media. This is adventitia, and this is the fibrotic plaque. No calcium here. You can see that. Then one soft plaque, which actually Ritik has shown in his patient, not as bright as adventitia. Hypoechoic, soft, refers to low echogenicity, generally due to high lipid content and mostly cellular lesions. And I think Dr. Kamal also mentioned about the macrophage, those kind of things. They're very soft and mostly cellular lesion. This is a concentric fibrophatic plaque, then eccentric fibro. This is an eccentric. Can you see the eccentricity? Eccentric. This is concentric. Vulnerable plaque. That is what we discussed. You can see this is a lipid core. This is a fibrous cap. I will show some pictures in OCT also. So this is catheter. This is a thin fibrous cap, and this is a lipid core. Macrophage is also. You don't see macrophage in IVAS. Mixed plaque. This is a very common thing. This is a catheter. There's a lumen, and there's varieties of mixture, fibrosis, bit of calcium, and very dense fibrosis. And these are, and then spotty calcium here and there. This is the kind of mixed plaque. That is the characteristic of mixed plaque. Thrombus. Intraluminal mass, lobulated or pedunculated appearance. Relatively echolucent. Stagnant blood flow can simulate a thrombus. Injection or contrast of saline may disperse this stagnant flow, clear the lumen, and appears black and allows differentiation of stasis from thrombus. So if you think this is blood stasis or a thrombus, when you inject contrast, you see the saline or contrast will disperse the stagnant flow, clear the lumen, and therefore it will allow the differentiation from the stasis from thrombosis. That is very important way. This is a thrombus. This is a typical varieties of pictures are there of thrombus. This is IVAS appearance of thrombus. This is a typical IVAS image of coronary artery thrombosis. Full of thrombus. Can you see that? In between there are some echolucency also. Very heterogeneous It's a mixture of that. I was showing atheromatous plaque. As I told you, this is the atheromata. This is atheroma. This is normal vessel, 3 millimeter diameter. And then this one is 3.1, but this is the kind of atheroma plaque. And then you can see the angiogram where you cannot make anything out of that. In angiogram, angle of view determines what you see. Whatever is your angle by the CR, that will tell you where is the lesion. But IVAS is actually give you much better. So angiogram silhouette is 75%, 25%. It may vary from coronary cross-section to angiogram. So cross-section says 25%, that makes sense. So there's a lot of variation. Angle of view determines what you see. Coronary remodeling hypothesis, again I said, this is a remodeling. This is not normal. This is minimal coronary artery disease, moderate and severe coronary artery disease. Expansion overcome, lumen narrow. This is severe coronary artery disease. Remodeling classification, we call positive remodeling, intermediate remodeling, and negative remodeling. This is a proximal reference, positive remodeling, intermediate remodeling, and then distal reference. So these are you have to understand that which one is negative remodeling, which one is positive remodeling. You can see the lumen, and then you can see the vessel diameter, which is very, very important. In positive, this is negative, becomes bigger, isn't it? This is the lesion. So in a positive remodeling, it looks very big. The measurement, as I told earlier, external elastic membrane, cross-sectional area, total arterial cross-sectional area, tracing the boundary between dark media and the bright adventitia for this external elastic membrane cross-sectional area measurement. Lumen cross-sectional area can be measured. Maximum and minimal lumen diameter. Stent cross-sectional area also can be measured. Maximum and minimum stent. Nowadays, there is a lot of software inside the IVAS. You can actually click those and get the whole thing. Plus media measurements. Everything can be done through this, including intima, hyperplasia, and stent. Measurements of analysis also can be done. Calculating cross-sectional luminal area. This is the luminal area cross calculation. You can see 5.9. Luminal diameter measurements. Stent to stent in in-stent restenosis also. This is a coil stent. This is a normal tubular slotted stent. That's how it is being done. In-stent restenosis measurement. In-stent intimal hyperplasia often appears with low echogenicity. So we find that this is a stent, and then you got a subintimal hyperplasia. Then you can actually find out this. And sub-stent hyperplasia also is very much noted. That is the mechanism of in-stent restenosis. IVAS is able to pick precise measurements and access lesion morphology, assess the lesion severity, assess the unusual lesion morphology, aneurysm, calcium, thrombus, measurement of vessel size, vessel length, determination of final result of intervention, and assess complication. Then lesion severity. The left main stem disease. This is the left main ostium, and it looks like osteal stenosis angiographic resulting in CABG or even redo. But on IVAS, no significant plant by IVAS performed after the graft closed the second time. Nothing, absolutely normal. So sometimes it would like this patient had another case. You can see that there is osteal stenosis of circumflex. This is our case. And we have done IVAS. This is IVAS. This is IVAS 1. It again shows a lot of plaque, especially that you will see circumflex osteum is very narrow. This is intima. You can see there is a plaque here. Progressively coming towards the bifurcation. And then LED, and then you can find out little bit of calcium there. very tiny. And then we have done angioplasty. Very nicely done. Repeated IVAS, all gone. There's a stent. So IVAS, we can give us a distal left main length, ostial LAD length, proximal LAD length, ostial circumflex, and all those measurements could be obtained with the help of IVAS. Then this is an example of instant restenosis, under expanded stent causing instant restenosis. IVAS is a very nice picture to show that. This is a volcano. Stent sizing can also be done by IVAS. We can actually do IVAS stent apposition, stent expansion, and age dissection can be minimized with the appropriate use of IVAS during today's angioplasty. So optimum stent deployment, there is a criteria. We have to follow that. 5 mm balloon needed. Then we know what is the optimum balloon size to be taken up for adequate apposition and adequate stent expansion. So very useful. If you have a minor age stent dissection, that also can be taken care of with the help of IVAS, and then you put on more stent. Late stent malapposition can also be identified by IVAS. CTO can also be done through IVAS guided. You can find out the true lumen and false lumen IVAS. Then accordingly, you can advance your guide wire and find out the true lumen and then advance the guide wire to track it through the totally occluded segment, particularly chronic total occlusion segment. IVAS is a very, very useful tool for such procedure. So it is an important tool to find a landing zone, especially in diffuse disease vessel. Marking technique is very helpful. The bookmark is very helpful. If you find unique IVAS finding like attenuated plaque, concomitant use of aspiration catheter, and distal protection can be done. Age injury can be picked up by IVAS. IVAS assists in percutaneous coronary intervention, is research tool, and very good tool for the publication of data collection and follow-up for long-term clinical outcome. After that, a very quick word about OCT, optical coherence tomography, has emerged as one of the most promising intracoronary diagnostic tools. This high-resolution technique with an actual resolution around 15 micromillimeter can be compared with 150 micromillimeter of IVAS, which allows a level of detail which was never reached before. OCT has provided new insight into the vessel wall and stent interaction, interface segment, plaque evaluation. OCT permits very accurate assessment of stent apposition and coverage. OCT is especially important in the era of drug-eluting stent and is potentially helpful to understand the risk of stent thrombosis. Regarding plaque characterization, this high resolution allows the measurements of fibrous cap, contributing to the identification of coronary plaque at high risk rupture. Likewise, plaque rupture responsible for acute coronary events. Intracoronary thrombus can also be visualized to a great deal with the help of OCT. This is an example of OCT image. This is a stent, and you can actually see that you can see that on the stent there are certain deposition which can be picked up later on. So there's a difference between the OCT and IVAS. So IVAS uses as a backscattered ultrasound. OCT uses reflect light to create cross-sectional images of the vessel. Since the speed of light is much faster than the sound, and interferometer is required to measure the black shattered light. This interferometer splits the light sound into two arms, a reference arm and a sample arm, which is directed into the tissue. When the back reflection optical intensity of the two arms is measured and compared, the optical properties of the tissue can be reduced since the light is not able to penetrate the red blood cell. So the blood needs to be removed during OCT. So you need to use contrast. In fact, you can also use what is called Dextran. Many people try to use Dextran. This is the OCT machine. Nowadays, it changed a lot. This is a dragonfly catheter, and that's how it can be done. Here's some images of OCT. You can see there is something over there you can see clearly there is a dissection. There's a lesion there. You can see that this IVAS, this OCT. You can see more detail about the OCT as compared to IVAS. Even the calcium also can be picked up very nicely. Instant restenosis, mechanism of instant restenosis can also be picked up very nicely by OCT, whether it is intimal hyperplasia or neointimal hyperplasia, as often is found in absorb, which I found in our own series of cases, and or something else that also can be picked up by OCT. Very nice resolution. These are some of my cases which I did with dextran instead of contrast. Instant late loss can also be picked up by OCT. And then you can actually take a longitudinal view and find out the detailed nature of the vessel along its length. In fact, the new generation of OCT can give you the very nice display of the vessel wall after OCT. So prepare the catheter, purging the saline, calibrate the optical probe, advance the catheter about 0.01 for guide wire and till the tip optical probe distal to the region of interest. Then start contrast or diluted contrast injection through the guiding catheter. But again, you have to remember the OCT itself also has problem. It can actually cause ischemia, arrhythmia, air embolism, fracture, coronary spasm, coronary dissection, and thrombus formation. You should be aware about that. And we have done quite a good number of OCT in our practice. And I've been using OCT for many years. In fact, first generation of OCT, then second generation, now we are having third generation right now. And I actually, in my initial practice, I had some problem of arrhythmia with ischemia, but not a major problem. Nobody actually had any catastrophe after OCT uses. This is the dragonfly catheter. This is the detail of those catheter, which I need not get into all those details now. This is how the light goes, measurable beam profile, and how the light goes. So it can be done in pre-intervention, plaque characterization, lipid, calcium, fiber cap thickness, thrombus, intervention planning and stent sizing, special lesion diameter length. After intervention, stent strut malposition, intimal dissection, and then follow-up, which is very, very helpful, especially for the neointimal growth. No coverage, thin coverage or restenosis and instant thrombosis. For these purpose, follow-up, the unique tool, no doubt about that. So this is a reference, this is a technique of measurement of OCT, lumen morphology at potential culprit site. The tissue differentiation can be done, minimum lumen area and diameter identification can be done by OCT. I think I'll close it here. This is a stent follow-up. So I've been using OCT in a variety of clinical conditions, visualizing plaque characteristics, stent apposition, tissue prolapse, age dissection, and follow-up of stent malapposition. So normal OCT image obtained in normal left coronary artery. Normal OCT. Artifact, there are a lot of artifacts, remember that. If you do not flush it well, then you can actually get a lot of artifacts. These are the kind of thing which I found. This is the kind of cases which I've done in 2013, 10 years ago, and you can find a lot of artifacts. They're all artifacts. And I think the patient had absorbed. And then you can have this is absorbed stent. This is a calcium. Calcium looks here completely different, like a rock. This is a classical optic form. This is a classical optic form. Classical. You can see how nasty the coronary artery could be when there's a lesion. You can see there's a very complex coronary artery disease of a STEMI patient and can also detect thrombus, which is not seen by angiogram. This is a thrombus, very nasty looking thrombus here. CTO also can be picked up. OCT is one such case of CTO which we have done OCT. So OCT might be efficient in complex intervention, including treatment of left main, ostial, left anterior, descending, or left circumflex. Remember, the only problem of left main that you have to inject it very well so that it should be completely free because it's very close to the aorta. So blood can get filled in. So limitation, ostial lesions sometimes can be missed. Use of contrast limited in patients with CKD, and imaging distal lesion is difficult because the wash away of contrast is very, very difficult. This is one of my cases where absorb was implanted. For absorb, very difficult with IVAS, but nice tool, OCT is still nice. But nowadays we don't have absorb, so it's not very relevant now. Thank you very much for your attention. Hopefully This will be of some value to our postgraduate student. Need not be the entire thing, but some highlights regarding IVAS and OCT will carry some impression in your theory exam as well as in practical questions. Thank you very much.
Thank you, Dr. Chakravarti. Fantastic talk, wonderful elaboration and description of IVAS as well as OCT. And I think a lot of questions that I'd asked Dr. Ghoshal about thin fibrous cap, TCFA, or the shoulder, or the macrophage were also touched upon very thoroughly by Dr. Robin Chakravarti. And any closing comments, sir, Dr. Mandal?
Yeah, this is fantastic. In fact, explanation by Robin. So I think it will be helpful for the students.
So it was covering basics of IVAS OCT that's a resident under preparation for an exit exam should know, and on even beyond, somebody who's learning how to do an IVAS and OCT. So thank you very much, Dr. Robin Chakravarti, for this wonderful.
Thank you, Kamal. Thank you.
Thank you, sir.
So thank you, everyone. Over to Robin Gulati and Dr. Charmi.
Thank you so much, sir, for taking us through to the entire course of this 1.5 hour wonderful session. Apart from, it's a really heartwarming session what we had today, and this is the entire course of program which is being really appreciated across board by various EMPG students, and I'm sure today's session would have been really, really interesting and a lot of learning coming out too from this one as well. Once again, I would like to extend my heartiest thank you to all the panelist members over here, and thank you, Dr. Ritu Ghoshal, for your presentation for the case today. And with this, we sign off for the day. Thank you so much, audience, for your participation, and we'll come back again on the next weekend, same time, 7:30 p.m. On the Saturday. So please do join us for one more wonderful case and one more wonderful session. Thank you so much. Please take good care of yourself. Good night and see you again.
Good night.
Good night,
Bye-bye.
sir. Good night.
Thank you, sir. Good night.
Good night.